All right. All right, we'll get started. Hi, I'm Victor Mangona. I'm a radiation oncologist at the Texas Center for Proton Therapy in Dallas. I did my training at Beaumont Hospital for residency, and then I went and did a pediatric and proton fellowship at MD Anderson Cancer Center in Houston. After fellowship, the Proton Center in Dallas opened up, and so I'm treating a bunch of kids over there. It's about half of my practice. I treat about 60 to 70 kids a year, and kids come from all over Dallas and North Texas, and some from elsewhere. So I'm very happy to be able to do the pediatric review for you guys. This is some dense material. It's a lot of pediatrics in a short amount of time, so bear with me. This part is difficult for me too. It's pretty dense. So we'll first start here with we're going to do the first half will be the pediatric tumors, solid tumors, brain tumors, and then we're going to go into the solid tumors later. Okay, so this first section here is just an overview of pediatric brain tumors, and this is a lot of what I do personally because I'm at a proton center, and we get a lot of the CNS tumors come up to me. So this is a breakdown of different cancers in children up to age 15. It's interesting when you look at different places, they all have, if you basically break it down by different age groups, different stratifications in terms of percentages, but this gives you a good idea overall of the proportions of children's cancer, most of which, or the largest portion of which are leukemias. And a lot of that is why survivals have gone up, because leukemia, we cure the vast majority of the ALLs, and they make up a good chunk of those. Okay, the CNS tumors is 22%, lymphoma over here 11%, and then the solid tumors, various solid tumors in a smaller proportion. Okay, so brain tumors in children, these are actually the most common solid tumors overall in childhood, and after leukemia, they're the most common. 45 per million person years is the incidence of pediatric brain tumors. So they're relatively rare. I see a lot of them, but they are generally rare. About 3,800 in the country, so about 10 per day in the United States. Okay, so the distribution of histologies, PNETs, or medulloblastomas, are about 20%, and pilocytic astrocytomas are about 20%. So interestingly, the term PNET, primitive neuroectodermal tumor, even though it's utilized often in the literature, the WHO basically got rid of that term. So it's kind of a vestigial term, but we still use it all the time. So medulloblastoma would be a PNET in the posterior fossa, and then if it's outside the posterior fossa, we don't really call them medulloblastomas anymore. They just call them PNETs, or really embryonal tumors. Okay, pilocytic astrocytomas, 20%, and then low-grade and high-grade astrocytomas. Then we have our pediatric specific tumors like ependymoma, craniopharyngioma, smaller down here. And then we have these very rare choroid plexus tumors, germ cell tumors, pineal tumors in less frequency. So here's a breakdown of the location, the percentages. So about half of them are going to be supratentorial, and half of them will be, hit the wrong button. Half of them will be infratentorial, half of them will be supratentorial. Okay, so you see here, okay, like 37% are gliomas. These midline tumors, craniopharyngiomas, occur right over here in the suprasellar region. Pineal tumors over here. Germ cell tumors can be in either of these two places. You have your optic pathway, hypothalamic chiasmic gliomas up here in number 1. Okay, and then your posterior fossa tumors. Brainstem gliomas. Medulloblastomas occur in the fourth ventricle alongside with ependymomas. And then you have your cerebellar astrocytomas, like your pilocytics, which are often located here. Okay, and this is a bigger graph, and this breaks it down by age, and the frequencies change as you go from younger age to older age. Okay. For example, medulloblastomas and the PNETs are more common in the younger ages from 0 to 10, and they become less common in the preteen and teenage years. Okay, pituitary tumors are very rare in young children and much more common in the adolescents. Okay, so I often see teenagers with germ cell tumors, and then you'll see like kindergarten age, elementary school age children with medulloblastomas, and then also ependymomas in the very young children. Okay, this is a graph of the average rate per million of these different tumor subtypes. Okay, so here's your brain tumors, and as children get older, brain tumors are less common. Okay, in black down here are the ependymomas, so they're much more frequent in the young ages from 0 to 5, and then much less frequent. The PNETs, the same. They start up more commonly at younger age and then they go down. Okay, astrocytomas are relatively even. Okay, and other gliomas also relatively even, but definitely some of them show a propensity to go down in frequency as they get older. Okay, and this is survival based on subtype and based on age. I'm based on some old SEER data. Okay, so astrocytomas, these are a wide group of histologies, but have about 70 to 75% survivals. Okay, other gliomas over here in the next row, between 50 to 80%. Ependymomas, we actually do pretty well for them as long as they're old enough to get good, effective treatment. So once they're in the age 5 or older group, we have around 70% to 80% survival. The very young children, the survival is very low. The same thing goes for medulloblastomas and PNETs. The infant survival rates are much lower, and that's a combination of different things, but a lot of it is the treatments are very aggressive and the toxicities would be very high in very young age groups. So we don't necessarily give them the same treatments when they're that young. Okay, so the written boards loves these genetic syndromes because they make for objective test questions because it's a multiple choice examination. In real life, not necessarily as directly applicable to day-to-day practice, but certainly on a multiple choice examination, knowing these syndromes can be very useful, and the genes and chromosomes associated with them, and they'll show up all over the written boards in different areas because these different syndromes have different malignancies associated with them. So, for example, neurofibromatosis type 1 and 2, very common. NF1 optic pathway gliomas are very common in children, and we actually don't really treat them with radiation. We just observe them for the most part, and they often go away. Okay, and that's the NF1 gene. We know NF2 is well associated with vestibular schwannomas, particularly bilateral, okay, and meningiomas, but also ependymomas and spinal cord astrocytomas. VHL, your von Hippel-Lindau, is associated with hemangioblastomas with the VHL gene. Tuberous sclerosis has the 2 TSC genes over here, and that's associated with subependymal giant cell astrocytomas, or so-called SEGAs, S-E-G-A, okay, and cortical tubers. Li-Fraumeni is associated with P53 and associated with astrocytomas and PNETs. You have Cowden syndrome, that's associated with the PTEN gene. Okay, and it's associated with this entity called dysplastic gangliocytoma of the cerebellum. I've never seen one. Turcot syndrome, however, is associated with medulloblastoma and glioblastoma, and nevoid basal cell carcinoma associated with medulloblastoma. Okay, so the CNS tumors in infancy, when they're very young, they'll often present with expanded sutures because they're not closed all the way. So they have like a bulging fontanelle in their soft spot in the front. Have macrocephaly due to the hydrocephalus and outward pressure, and impaired upward gaze, so we call the settling sun sign or a superior gaze palsy, failure to thrive, cry, and emesis. Okay, you can also see asymmetry, diencephalic syndrome, loss of milestones, and Paranode syndrome. These all kind of go together, and a lot of them are related to increased intracranial pressure. Okay, as they get older, the symptoms that children present with are different. So more commonly, with the increased intracranial pressure, they'll complain of headaches. Okay, they don't have the bulging fontanelles because they're closed. They will have headaches, they'll have nausea and vomiting from the increased pressure, have diplopia, ataxia, and then also, again, the impaired upward gaze, so Paranode syndrome. Okay, they can have seizures, weakness, difficulty in school, and other neuroendocrine deficits. And a lot of this just depends on what kind of tumor, how long it's been growing, its what type of onset it has. Okay, so again, I said about half of them are supratentorial and half of them are infratentorial, and we showed that picture previously. Okay, and so ultimately they present with whatever the local symptoms are based on the location. So if they present with a seizure, that's more often associated with a cerebral location, particularly if it's in the temporal lobe or near the temporal lobe. Suprasellar tumors, they can occlude the foramen of Monroe, and so the fluid pathways are obstructed, causing increased intracranial pressure. Okay. Because it's suprasellar, the optic pathways are right there, and that causes a deficit in visual fields. And then in the suprasellar area, the pituitary and the hypothalamus are there, so they can have precocious or delayed puberty, delayed growth, obesity with hypothalamic dysfunction. This is how a lot of children, for example, with craniopharyngioma will present, is with short stature and obesity. Okay, so breaking down some of the genetics here again, NF1 in more specificity is an autosomal dominant gene on 17q. Okay, this is associated with about 1 in 5 to 1 in 6, or 1 in 5, 1 in 6 patients with NF1 will develop some sort of a glioma, in particular an optic pathway glioma. So it's very common. It's still, if you look at all patients with optic pathway glioma, not necessarily the majority of them have NF1, but NF1 has a very high propensity toward optic pathway gliomas, and they tend to be indolent. Okay? Tuberous sclerosis also is associated with renal insufficiency. Okay? Li-Fraumeni syndrome we said here. Okay? And then radiation, beyond the genetic factors, is one of the highest risk factors for a CNS tumor. And we see that a lot more now that we have long-term survivors of children with history of radiation. Every few months I hear about another kid who's like a 15 to 20-year survivor from medulloblastoma, and they have a new meningioma pop up. Okay, so that's the intro. I'm going to see if I can pull up the next slide.